In modern medicine, blood transfusions are a fact of life. This is often reflected in questions on the boards, which expect you to know a few basic problems that can arise with them, which are often autoimmune in nature. One of the most basic is a simple allergic reaction to proteins in the transfused blood. This manifests with typical allergic reaction symptoms, such as hives, itching, wheezing, and fever. You can treat this with basic antihistamines. Similar, but much more severe in nature, a patient can have an anaphylactic reaction to transfused blood, which can lead to symptoms of shock, such as dyspnea, hypotension, and respiratory arrest. One type of type 2 reaction you might see is febrile non-hemolytic transfusion reaction. This involves attack by host antibodies of donor HLA antigens, resulting in nonspecific symptoms like fever, headache, chills, and flushing. A more dramatic example of a similar phenomenon is acute hemolytic transfusion reaction, which is what occurs when you have a transfusion of a frankly mismatched ABO blood type. It can lead to intravascular or extravascular hemolysis, which can lead to fever, hypotension, tachypnea, tachycardia, flank pain, blood in the urine, and jaundice. This is a moderate yield topic, and a nice way to pick up some extra points on your boards. I won't go through and read them all to you, but I will recommend you spend some time memorizing these associations, then test your knowledge with the workbook. So this is just sort of a broad overview of how different forms of immunodeficiency can affect your ability to fight off different pathogens. Let's go through this slide really quickly. The most important deficiencies when it comes to bacteria are deficiencies in B cells and complement. A deficiency in B cells will give you a picture much like a splenectomy patient, in which the individual will be much more vulnerable to infections from encapsulated bacteria, namely Streptococcus, Staphylococcus, Haemophilus, and Moraxella. Lack of complement, as mentioned earlier, will lead to multiple Neisseria infections. When it comes to viruses, a lack of T cells will predispose you to infection by members of the herpes virus family, as well as chronic respiratory and digestive viruses. A lack of B cells is perhaps even more dangerous, as it can lead to contraction of severe viral diseases such as encephalitis and polio. Fungi and parasites are probably low yield in terms of committing to memory, but if you remember one thing, remember that a lack of granulocytes can lead to repeated Candida, Nocardia, and Aspergillus infections. And just as sort of a general summary and side note, you may want to remember that there's a general pattern that a lack of B cells can lead to bacterial infections, where a lack of T cells leads to fungal and viral infections. The immune deficiencies are a very high-yield concept for Step 1, and fortunately can be quite simple to remember if you recall the roles of the players in the immune system and appreciate how absent or deranged components might manifest clinically. There are numerous ways to organize the immune deficiencies, and you should certainly pick a way that you find the most useful. For the purpose of our discussion, we'll divide the immune deficiencies on the basis of which immune system component is deranged. The B-cell disorders include Bruton's A gamma-globulinemia, hyper-IgM syndrome, selective Ig deficiency, and common variable immunodeficiency. Here we see the first disease, Bruton's A gamma-globulinemia. Before we go further, what do you think is the derangement in this condition? You're correct if you infer from the name that B-cell function is effectively absent in this condition. This X-linked recessive disorder results in a defective tyrosine kinase gene that blocks B-cell differentiation and maturation. Lab values demonstrate normal levels of pro-B cells, but with decreased maturation and production of all classes of immunoglobulins. The clinical manifestation of Bruton's is classically a young boy due to the X-linked recessive genetic transmission, with recurrent bacterial infections after 6 months of age. Can you think of why this disease is a delayed presentation? After 6 months, non-breastfeeding infants lose the protection of maternal antibodies, must rely on their own immunity much more. Think of why patients with Bruton's A gamma-globulinemia might be more susceptible to bacterial infections. What role do immunoglobulins play in bacterial defense? Recall the role antibodies such as IgA and IgG have against bacteria. IgG opsonizes bacteria, making them more susceptible to immune surveillance and intervention, while IgA prevents adherence of bacteria to mucous membranes. Also recognize how these two immunoglobulins are differently present in the perinatal period, thanks to the ability of IgG to cross the placenta and the presence of IgA in breast milk. What lab data might you expect to find in a patient with hyper-IgM syndrome? This condition, characterized by a defect in the CD4 ligand of helper T cells, results in an inability of B cells to undergo class switching. As a result, one sees elevated levels of IgM, as expected from the name, but also depressed levels of IgG, IgA, and IgE. Clinically, this condition presents as severe pyogenic infections early in life. Selective immunoglobulin deficiency, as you would expect, results in depressed levels of specific immunoglobulins depending on which flavor of the condition a patient has. IgA deficiency is the most common due to a failure of B cells to mature into immunoglobulin-secreting plasma cells. Think for a moment what clinical presentation you would expect. Patients affected by IgA deficiency experience sinus and lung infections, as well as milk allergies and diarrhea. One of the more life-threatening manifestations of IgA deficiency is the risk of anaphylaxis upon exposure to blood products containing IgA. As a result, patients with this condition must be given washed red blood cells. Common variable immunodeficiency, interestingly, can present as late as the third or fourth decade. This condition has numerous causes, all of which converge in the common feature of defective B cell maturation. This results in a normal number of B cells, but a decrease in the mass of plasma cells, and consequently immunoglobulin. Patients with CVID are at increased risk of autoimmune diseases, lymphoma, and, not surprisingly, sinopulmonary infections. Let's turn our attention now to the immune deficiencies involving T cells. DeGeorge syndrome, or thymic aplasia, results from the failure of the third and fourth branchial pouches to develop into a thymus. Children with this condition experience recurrent viral and fungal infections as a result of their T cell deficiency. Additionally, these patients have characteristic facies including cleft palate and often heart and great vessel defects. Other sequelae of the failure of development of the fourth branchial pouch are the absence of parathyroid glands, which leads to hypocalcemia manifesting in tetany. This devastating condition is the result of a deletion at chromosome 22q11. The mnemonic catch-22 is often used to remember the cause of the syndrome and its manifestations. Cardiac anomalies, abnormal facies, thymic aplasia, cleft palate, and hypocalcemia, hypoparathyroidism. IL-12 induces T cells to differentiate into Th1 cells. A deficiency in the receptor for IL-12 thus diminishes the Th1 response, which can lead to disseminated mycobacterial infections. Hyper-IgE syndrome, also known as Jobs syndrome, arises when Th cells fail to produce interferon gamma, which ordinarily incites neutrophils to respond to chemotactic stimuli. Patients with this syndrome also manifest characteristic horse facies, as well as non-inflamed staphylococcal abscesses, retained baby teeth, and eczema. Not surprisingly, IgE levels are elevated in this condition. T cell dysfunction can also result in chronic Candida albicans infections of the skin and mucous membranes. Some immune deficiencies are the result of both B and T cell dysfunction. Severe combined immunodeficiency, also known as SCID, which was publicized by the Bubble Boy, clinically presents with recurrent viral, bacterial, fungal, and protozoal infections. It's important to recognize that there are several forms of SCID. The most common variant is X-linked, resulting in a defective IL-2 receptor. IL-2, you'll recall, stimulates growth and proliferation of cytotoxic T cells. SCID also manifests as an adenosine deaminase deficiency, and as a failure to synthesize MHC2 antigens. As an interesting side note, it was also the first human disease in which gene therapy was attempted as a cure. Ataxia-telangiectasia is the result of a defect in the ATM DNA repair enzyme gene. It presents with another classic triad: cerebellar defects, which lead to ataxia, spider angiomata, which are a form of telangiectasia, and IgA deficiency. Wiskott-Aldrich syndrome results in the progressive deletion of B and T cells. Immunologically, this manifests with thrombocytopenic purpura, infections, and eczema, and it's characterized by increased levels of IgE and A with decreased levels of IgM. Finally, we bring our discussion to the immune deficiency states that arise from phagocyte dysfunction. Leukocyte adhesion deficiency arises from a defect in the LFA1 integrin protein on phagocytes. Integrins mediate cellular interactions. The result of this condition is recurrent bacterial infections, absent pus formation, and delayed separation of the umbilicus. Histologically, this condition is characterized by neutrophilia. The autosomal recessive Chediak-Higashi syndrome results in a defect in microtubule function. Patients experience recurrent pyogenic infections from staph and strep. These patients may also manifest partial albinism and peripheral neuropathy. Lastly, our discussion arrives at chronic granulomatous disease. The defect in this condition is that neutrophils lack the enzyme NADPH oxidase. The inability to generate reactive oxygen species for the respiratory burst renders neutrophils ineffective, and patients have an increased susceptibility to catalase-positive organisms. The presence of this condition is confirmed by a negative nitroblue tetrazolium dye test, where the absence of superoxide prevents reduction of the dye. This test is positive in patients with normal neutrophil function. With grafts, the greater the HLA compatibility, the more likely the graft is to succeed. HLA compatibility is greatest when the graft is from the patient's own tissues, or when the tissue is from a closely related person. When none of these tissues is available, surgeons must turn to allografts, which are from non-related donors, or even xenografts from other species. For example, bovine pericardium is commonly used as a dural graft after brain surgery with excellent results. There are 4 forms of transplant rejection, all of which are immune-mediated. This, of course, explains the essential role of immunosuppressants in protecting transplanted organs from the recipient's immune defense. With these, you'll want to pay special attention to the time frame during which each occurs, as well as features. Hyperacute rejection is the earliest manifestation of transplant rejection as a result of preformed anti-donor antibodies in the recipient. Occlusion of graft vessels leads to ischemia and necrosis of the transplanted organ. Acute rejection, which typically occurs weeks after transplantation, is a cell-mediated reaction due to cytotoxic T cells reacting against foreign MHCs. Fortunately, this form of rejection may be reversed with cyclosporin and OKT3. Histologically, one sees vasculitis with a dense interstitial lymphocytic infiltrate. Chronic rejection occurs months to years after transplantation and is characterized by obliterative vascular fibrosis due to T cell and antibody-mediated damage. Unfortunately, this condition is not reversible. Graft versus host disease is a fascinating condition in which grafted T cells proliferate in the immunocompromised host and reject host cells. The result is a condition characterized by macropapullar rash, jaundice, hepatosplenomegaly, and diarrhea.